Sandy Khurana. I'm a professor of medicine, an adult pulmonologist at the University of Rochester Medical Center in Rochester, New York. My focus is adult asthma. We just wrapped up the CHEST 2025 meeting in Chicago, and I'm the chair of the scientific program committee. Lung health was the focus, and there are a lot of new and pipeline therapeutics available in multiple disease states, including in asthma and COPD, interstitial lung disease, pulmonary hypertension, bronchiectasis. So I think there was a lot of excitement around that. And I'd like to highlight two studies that were presented. One was the impact on dupilumab on mucus in the lungs. This was data from the Vestige study where they evaluated on CT chest imaging the change in the amount of mucus plugging, and the impact of dupilumab was significant and occurred within, you could see the impact within 4 weeks. There was significant improvement in lung function as well as small and large airways. So I think that was certainly something that caught my eye. The second was also in asthma and severe asthma, but in patients who have coexisting sinus disease, nasal polyps. And again, this was a comparative study between dupilumab and omalizumab. This was results from the Everest study. And again, it showed that dupilumab was more effective in improving asthma control and sinus disease in patients who have both of those conditions coexisting. So I think the future is really bright, and there are many things that are on the horizon, but there's work being done where you could have bispecific nanobodies. So you could have the same biologic that can target multiple pathways. And that I think could be, right now we are limited because it's really hard to get people on dual biologics. A need biologic is pretty specific in targeting a certain pathway, and having access to one biologic that can target multiple pathways, I think that is very exciting for me.
My name is Dr. Cosmo Fowler. I'm a sleep and critical care attending in the Piedmont system in Atlanta, Georgia. I have completed my training in critical care and sleep medicine. I did critical care at Sloan Kettering in New York, and I did sleep medicine at Emory. What this study attempted to do was to see whether the presence of a diagnosis of obstructive sleep apnea impacted the survival difference of patients with type 2 diabetes receiving a GLP-1 receptor agonist, which would include medications such as semaglutide and tirzepatide. This study was a retrospective work using a data platform that integrates de-identified electronic health record data of a pool of about 120 million people in the United States. The patients that I selected not only had a diagnostic code for type 2 diabetes, but also were on a medication for diabetes, metformin, which is the standard of care, and people with diabetes. I asked the question, if we select those that have sleep apnea and we make a sleep apnea and a non-sleep apnea cohort, and then we look at how their mortality maps out if they were prescribed a GLP-1 RA or not prescribed a GLP-1 RA, and then we try to match them so that they're as similar as possible, whether they have high blood pressure, whether they have this body mass index, whether they have this hemoglobin A1C. Do you see more of a survival benefit in the patients with sleep apnea than in the patients without? And in comparing the sort of effects, there was a disproportionate survival advantage observed in the patients with the diagnosis of sleep apnea, about a 20% relative advantage to the non-sleep apnea patients. My takeaway is that patients with sleep apnea potentially stand to benefit disproportionately from the prescription of a GLP-1 RA agent. I can't say necessarily, at what body mass index threshold, at what severity of sleep apnea does this change based on their treatment. These are things that we are not privy to based on the nature of the platform. People are doing GLP-1 RA research for Alzheimer and addiction and heart failure and kidney disease, and pretty much pretty much anything you can think of. These medications are showing very surprising and interesting benefits. So I think specifically with sleep apnea, the question will be: so which specific GLP-1 RAs are really benefiting patients? What are their long-term survival outcomes? Does it matter if the patient has mild, moderate, or severe sleep apnea? Does it matter if they're adherent to positive airway pressure? What if they're in some other form of treatment? Does everyone benefit the same way? Who benefits the most? I think this is where data that is currently being collected prospectively is going to shed valuable light.